The American Healthcare Association and National Center for Assisted Living are pleased to present today's program, Report, State of the Skilled Nursing Industry. It is now my pleasure to introduce Beth Martino. Welcome, Beth.
Thanks, Kendra. Welcome to all the members of the media that are joining us today. Thank you for your time. I am Beth Martino. I'm the Senior Vice President of Public Affairs at the American Healthcare Association. Today, we are presenting to you a report on the state of the skilled nursing industry, and I'm going to turn it over to our speakers. Just a quick introduction. We have Mark Parkinson, the President and CEO of the American Healthcare Association and National Center for Assisted Living. We'll also have Deb Emerson, who's a principal with Clifton, Larson, Allen, who will present the findings from a report conducted by CLA. And then we will also have Nate Schema, President and CEO of the Good Samaritan Society. Mark will then wrap up, and I will help moderate a Q&A at the end of the presentation. As Kendra mentioned at the top, if you do have questions, please feel free to submit those in the chat, and we will return them at the end of the presentation. With that, I'm happy to turn it over to Mark Parkinson, the President and CEO of HCA and Cal.
Hey, thanks, Beth. And first of all, I want to start out and really thank the members of the media that are here with us this morning to hear about this really what we believe is eye-opening and very important study. It's extremely important to the millions of residents of skilled nursing facilities that these stories get out there, and your willingness to cover them is extremely important to us, and we are very appreciative. The purpose of today's meeting and press release and press function are to reveal the results of what we believe a very important study that Clifton, Larson, Allen has performed that provides us an analysis of where the sector stands financially in 2021. It's very hard to get up-to-date information on financial performance in our sector because reporting is often delayed and it's tough to get real-time analysis. The results that we see are often 6 months, 12 months, and sometimes even longer ago than that. As we talked to providers across the country, we became convinced that the financial state of the sector is actually much worse that's being reported by that information that is outdated. Some of the 2019 data and even some of the 2020 data, the first year of the pandemic, was showing numbers of positive margins and much better than what we were hearing from actual operators. So we asked Clifton, Larson, and Allen to do an analysis of what's actually happening in somewhat more real time. And unfortunately, as you'll hear in just a minute, the results are very sobering, and the sector is at deep risk right now. Before I get into my introduction of Deb and that report, I first of all want to make some comments about the White House release on its nursing home reform package that was briefly commented on by the president in the State of the Union address last night. I think as you analyze the report and the release from the White House itself, you really have to divide it into two categories. The first is the rhetoric around the report, and the second are the solutions themselves. And unfortunately, the rhetoric does not match the reality of what is actually happening in nursing homes. The premise of the rhetoric is that quality in nursing homes has gotten worse. Nothing could be further from the truth, and providers should be proud of the advancements that we've made in quality, particularly over the last 10 years. If you look at the time period before the pandemic, specifically if you look at 2015 to 2019, and the 20 quality measures that are used by CMS to measure quality in nursing homes improved on 16 of the 20. In 2 of them, we stayed the same, and in 2 of them, we fell back slightly. But the overwhelming objective data, not the anecdotes and not the adjectives, but the real data shows that we have made significant improvements in nursing homes over the last 5 years and even the last 10 and 15. And that hasn't happened because of more government regulation or more fines or more penalties. It's happened because we wanted to get better. The quality initiative that AHCA itself developed that we collaborated with CMS on is what has resulted in these improvements. And to suggest that nursing home quality has declined is simply factually inaccurate. Indeed, you can look at the last 2 years of the pandemic itself to really demonstrate the success of the sector. We faced two horrible things that occurred over the last couple of years. The first was the pandemic itself, the virus being particularly damaging to older people and being incredibly contagious, victimized our residents and our staff and made care very, very difficult and led to the tragic number of deaths that we've seen. But we've also been victimized by public policy. There have been very poor decisions that have been made on a bipartisan level, initially to not prioritize nursing facilities, to not give us the PPE and not give us the testing that we needed. Later on, decisions that were putting people in nursing homes that had COVID, that where the nursing homes themselves did not have the testing or equipment to provide safety to the other residents. There have been very bad public policy decisions made by both parties. The net result is that thousands of people have died. At the same time, the heroism of these facilities has saved thousands of lives. Our providers did not flee facilities. They ran towards them. They provided the care that needed to be provided, and thousands of lives have been saved. To now criticize the sector for what occurred over the last 2 years is both factually inaccurate. It's just based on a false premise, and it's really cruel because the providers have done everything possible to save lives and will continue to do so. Fortunately, the solutions that are offered by the White House are not as off base as the premise or the rhetoric around those solutions. I think if you look at the solutions, you can really divide them into two categories. The first is the minimum staffing requirement, and the second is everything else. The minimum staffing requirement is unrealistic and not possible. It ignores the fact that virtually every SNF in the country is unable to find the workers that it needs. The workers have simply left. Over 200,000 of them have left our labor force. It's also not realistic because the funding is not there. Fortunately, when you set aside the minimum staffing requirement, there are many other things that the White House calls for that are possible and that could improve quality. We agree that we need to focus on the poor providers. We need to help them get better. And if they can't get better, they shouldn't be providing care. And so to the extent that the administration is willing to focus on that part of the provider group, we'll be right there with them, arm in arm, trying to improve the poor providing facilities and get them better. But the continued attacks on good operators that are waking up every day, doing everything they can possibly do to provide great care, that are laying awake at night because they're worried about the residents in the buildings, we're just not going to stand by and let them get attacked. It's just not fair. In terms of COVID, where are we at? Well, here's the good news. The good news is that on the clinical side, things are much better. The dramatic decline that we've seen in cases in the general population has also occurred in skilled nursing facilities. We've seen a dramatic fall in the number of cases over the last 4 to 6 weeks. And so at least for some temporary period of time, maybe a long period of time, the clinical nightmare is behind us. Unfortunately, as we sit here in real time, the business side of this, the business nightmare continues. And it's really two things. It's a dramatic drop in census with essentially no recovery for the last 7 months. And it's this huge labor problem that I talked about earlier on. 238,000 workers have left our facilities. We're not able to fully staff them. We're not able to admit new residents. When you combine these two features, it creates a real problem for beneficiaries and for the residents of our facilities. We're unable to provide the care that we'd like to provide. We're unable to admit new residents to our facilities because we don't have workers. And the net effect has been devastating on our business. Again, if you look at margins in 2020, it doesn't provide the real picture. The huge labor problems develop at the beginning of 2021, and that's why we felt it was so important that we look at a study that would determine what exactly is happening in the facilities in 2021. So I'm now pleased to turn this over to Deb Emerson, who's a principal at Clifton, Larson, and Allen, who can walk us through the methodology that they utilize to figure out where we are at right now and the findings that they've made. Deb?
Great. Thank you, Mark. I appreciate that. As Mark said, the American Healthcare Association commissioned CLA to perform a study of the current and potential future state of the skilled nursing industry. So our report focuses on margins as well as cost of care and other contributing factors such as occupancy and labor cost to determine the financial status of nursing homes. So we really sought to take a holistic view of the state of the industry using available 2021 data, in addition to the 2020 data that was used by other studies available. So as we looked at the key findings and went through the data, we found significant risk associated with the sector using that 2021 data. Specifically, we noted increases in negative margins, the enhanced possibilities of closures, and challenges with access to capital. So there's a number of factors that play into this analysis, including the occupancy, inflation, labor cost, Medicaid rates, Medicare Advantage rates and penetration, as well as the Medicare PDPM. Next slide. So when we looked at the potential occupancy recovery for 2022, CLA laid out 3 different scenarios, all of which ended up with a negative median operating margin due to inflation and the increasing cost in labor and other areas. We estimate a median operating margin of negative 4.8% using the current trending occupancy recovery rate of 77.3%. Next slide. One of these examples in how skilled nursing facilities are facing increased labor costs and contributing significantly to the negative margins is the increase in hourly rates for nursing costs across all disciplines, RN, LPN, and aides. We're seeing the increase in those rates more than double in 2021. Next slide. We are also seeing an increase in contracted or agency nursing costs. From 2017 and 19 to a post-COVID environment, we're seeing 2 to 3 times the historical cost per hour for contracted nursing. Next slide. So as we look to 2022, we can see an operating margin of negative 3% to a negative 8%. And looking at those trending occupancies from 76 to 81%. The most important and telling aspect of this is looking at the average daily census, or those individuals that are in the facilities that are being served. So when we look at those negative operating margins in the facilities that are at financial risk, less than a negative 7.5% operating margin, we're seeing 32 to 40% of individuals being in facilities at risk. So next slide. The implications of these facilities at financial risk is very important. If facilities no longer receive enhanced Medicaid funding due to the end of the public health emergency and Medicare cuts PDPM rates by 5%, we estimate that more than 400,000 residents are going to be at risk of displacement. This would be a nationwide problem, and we see these residents living in more than 2/3 of the US counties. Next slide. As you can see, additional reimbursement decreases could only result in serious access and quality of care issues. Possible risks to the sector include a reduction in Medicare Part A fee-for-service rates through a parity adjustment, and also the end of the public health emergency funding. So now I'd like to turn it over to Nate with Good Samaritan Society.
Thanks, Deb. And my name is Nate Schema, and I'm the president and CEO of the Good Samaritan Society, one of the nation's largest not-for-profit providers, serving in 22 states and proudly serving over 12,000 residents. You know, much of our footprint is pretty rural, 70% in fact. And I just want to give you a little glimpse into what our reality has been. Just about 3 months ago, I personally stood before a group of family members, residents, and team members and announced closure in a 5-star community in Ravenna, Nebraska. Shortly thereafter, we announced closure in 4 other communities, 2 in Nebraska, 1 in Kansas, and most recently here in January, 1 in Greeley, Colorado. The pandemic has put unprecedented stress on our industry, which has forced us to make some incredible decisions. In some cases, or in many cases, we had plenty of residents to serve. We just didn't know, we no longer had the team members to support and serve them. Because we're a large organization, we're pretty blessed and fortunate that we were able to find agency team members and contingent labor all over the country to fill the gaps and holes, especially in those early days of the pandemic. But as the days wore on, it became increasingly difficult, where we saw our agency rates escalate to 2 and 3 times their pre-pandemic norms. And most of the time, or as is in the case in the upper Midwest, there weren't a lot of people looking to head to Bottineau, North Dakota, or central Nebraska over the winter months, putting increased pressure and basically forcing us to make some incredible decisions that I hope no other provider ever has to make. Persistent staffing challenges, declining census, increased operating margins, they've been a part of what we do and what we're trying to manage through day in and day out as providers. I wish we had the ability to pass on our costs, no different than one of my favorite Subway joints, Jimmy John's, and just pass those right on. But with over 50% of our residents receiving state Medicaid services, we just do not have that luxury. Today, we have nearly 2,500 open positions within our organization today. And while I'm incredibly proud of the heroes that are serving the society and who have truly stood up during this remarkable time, we just need more help. While we've done a lot of different things for our organization, we've been creative in finding solutions to invest in our team members. Over $15 million in 2021. We've really looked into how do we provide care differently. How, and fortunately, as a quality provider, we've seen our turnover rate be very favorable to the industry. However, the pandemic does not discriminate. And certainly, as Mark alluded to, with over nearly 240,000 people leaving the workforce, we are in an unsustainable and untenable situation. Since 2021, May of 2021, we have spent over $62 million as an organization in contingent labor on a budget of roughly $20 million, which equates to a 300% increase in our agency agency costs. We know that there will be implications to where and how our residents receive care in the future if more isn't done. Unfortunately, we know there's some communities, based on some of the decisions we made, that will have to go upwards of an hour to receive care, as there's just no other options in the future. We know that it is going to continue to be an access issue across the country if more isn't done by our government. The federal aid we'd received during COVID was life-saving, but it hasn't been enough, and we need to continue to do more because we're certainly not out of the woods yet. If we do not receive ongoing COVID assistance, and certainly if we receive additional cuts that Deb and Mark have alluded to, I'm deeply concerned about our ability to keep our doors open in many of our communities. It's critical that policymakers consider the whole picture and look at the totality of the impact the pandemic has had the 2 years, so that we may carve a new path forward. We owe it to our nation's seniors, their families, and our frontline caregivers who have heroically served these past couple of years. Thank you, and I think I'll turn it back over to Mark for some closing remarks.
Thanks, Nate, and thanks, Deb. And I mean, it is sobering to look at the Clifton, Larson, Allen report and see that over 400,000 residents are living in facilities that may not make it. And this is not crying wolf. I mean, Nate is the CEO of one of the premier organizations in the country and has talked about closure of 4 or 5 buildings here in the last 5 or 6 months. Fortunately, there are solutions. There are steps that policymakers can take to avoid this. And specifically, let me just outline a few of those. First, we've asked for the Provider Relief Fund to be replenished. We've specifically made an ask of $10 billion to skilled nursing facilities, which we think if we could receive would provide enough time for providers to get to census recovery and to get some of the workforce back so that the residents can be taken care of and that people would not be living in facilities that could potentially go under. Secondly, we need the public health emergency extended. It is currently set to expire in the middle of April. The Secretary of HHS has the authority to extend it for up to another 3 months to get us into July, and we strongly encourage that occur. That is important because there are multiple states that have Medicaid increases to SNFs that are tied to the public health emergency. It is also important because the temporary nurse aid program, a program that ACA developed, that over 250,000 people have been trained in, their ability to continue to work in facilities is also tied to the public health emergency. So it's critical that the Secretary extend that, and we encourage them to do so. And then finally, we just needed stable funding. We need the states that are underfunding Medicaid to step up and to take care of the beneficiaries in their states. We need the federal government, which of course is in charge of the Medicare program, to step up. The cries to cut us potentially 5% need to dissipate. We need to get rid of that discussion, and we need to move forward with stable rates. If policymakers would take those 3 steps, we believe that we can avoid the negative possibilities that the Clifton, Larson, Allen report outlines. But if the policymakers are unwilling to take those steps, we believe that, as we've seen with the Good Samaritan Society, there will be more closures, less access, and less availability to care for thousands, possibly hundreds of thousands of older people of this country. And we just can't sit by and let that happen. So with that, again, we appreciate you covering this, and we'll be happy to answer any questions that you might have.
Thanks, Mark, and particular thanks to Nate and Deb for their time today, and both the report overview and kind of the on-the-ground provider perspective from Nate. So with that, just a reminder to reporters who've joined us today that you can submit your questions via the chat. We'll give you a minute or two here so everyone can submit those, and then I'll share those with our speakers today. Okay, so we've got a few questions coming in here. I'm gonna start, Mark, I think I'll direct the first one to you, from Danielle Brown with McKnight's. She's just asking whether, as an industry, as a profession, we expected or had some idea that some of the initiatives proposed by the federal government this week were coming.
We did. We had some discussions with CMS officials briefly before they were announced, but even prior to that, there had been some discussion that if the administration was not successful in getting its agenda passed on the Hill, that it would do what most presidents end up doing, which is trying to get things done administratively. So virtually every one of the proposals that was outlined on Monday was attempted in the reconciliation bill up on the Hill, but obviously that bill was not successful. So we were not surprised that the effort that would then be to do it administratively. The good news is that a lot of this stuff can't be done administratively. It has to be done with congressional input, and I think the press release itself acknowledges that. But we were not surprised, and we expect that it would come at some point.
Thanks. Okay, the next question we have is from Alex Zorn with Skilled Nursing News. And Mark, I might start with you on this, but Nate and Deb, you may want to weigh in here as well. Alex asks, how concerned are you that President Biden's nursing home reforms could result in more nursing home closures? What would you like to be done to ensure there are no gaps in care?
Well, it doesn't have to lead to that, and all of this stuff will take time. And there are thoughtful people in the administration and over at CMS, and we need them to work with us and to work with people that are actually out there like Nate providing the care to make sure they don't make poor decisions. But if they had a minimum staffing requirement that if you were unable to meet, you could not operate, that would close every building in the country. There isn't a single building in the country right now that is fully staffed. And so they would be quite capable of making decisions that would accelerate the closures of buildings. But if they're thoughtful about this, that won't occur.
I would just add, I would love to be able to hire more people and fill all my positions today. And so it's certainly not for a lack of effort. As we look at solutions moving forward, additional funding or any additional mandate that comes through our industry, if it's funded, we absolutely are going to do everything that we can to meet the new intent of the regulations and involved. But certainly we just want to know that there's hope and a direction that we can best meet our residents' needs moving forward.
Thanks, Nate and Mark. So our next question is from Jesse Hellman with Modern Healthcare. The question is, wanted to ask about the cost of nurse staffing agency. There have been bills introduced in several states that would limit the rates charged by these agencies. Has AHCA been involved with this legislation? So Mark, I'll turn that one to you.
Yeah, I mean, unfortunately, the conduct by some staffing agencies across the country has just been despicable. At a time when nursing home providers and all healthcare providers have needed work, some staffing agencies have taken advantage by doubling and tripling the normal rates. That should not be allowed to happen. And so we've encouraged the federal government to look at it, but we really think our best chance is getting some regulation at some of the states that seem to be receptive to this. So we have been involved. We are a federation. We have 50 state affiliates, and we've provided all of them with some model language that they can use to try to get their states to put some caps on what happens with staffing agencies. Nate, I don't know if you've had any experience you want to talk about.
I see providers as having two options. They can pay the whatever rate that is being asked, and in many cases, or actually up until pretty recently, we've done just that. We've said, you know what, we're here to serve our communities, and oftentimes we are the only provider for miles around, and so we're going to do everything we can to bring in contingent labor. However, I think in my mind, it becomes a math problem, and that's the point we're reaching as an organization where it's just untenable and it's not sustainable moving forward. And so while we've seen some movement in some states, and Minnesota particularly has put some regulations forward, they've also, in many facts, rolled those things back because you don't want to be at a competitive disadvantage, because the environment is such that people will just move to the next state over where they can receive those escalated rates.
But Nate, just to kind of put some numbers on it, I mean, a typical rate for paying a certified nurse aide might be $15 an hour, but with an agency, you could be looking at $30, $45, $60, $75 an hour are reports we've seen.
Our average CNA rate right now is right between that $65 to $75 an hour. And LPNs and RNs, it's not uncommon to see those things $100, and RNs, upwards of $200 an hour right now.
Okay, thanks both of you for that answer. The next question we have is from Jordan with Skilled Nursing News. Jordan's question is, who has the ultimate power to set federal staffing minimums? Is that something that has to be put forth by Congress? And Mark, I'll start with you on that.
We think it probably needs to be a congressional decision. We think it should be a congressional decision. It's not clear from the White House release if they're planning on consulting with Congress on this or not. It looks like their plan is to do this on their own. It's not at all clear that they have the authority to do that. Okay.
Tim Mullaney with Aging Media is our next question. And Tim asks, do you believe that given the federal government's efforts to shift to home-based services rather than facility-based, they are in fact expecting SNF closures, given their recent actions, and believe that a lower number of facilities could be acceptable in the long term? That in fact HCBS would be able to take some of the displaced patients, for example. Mark and Nate, I suspect both of you could weigh in a bit on this. So Mark, maybe start with you there.
Yeah, our view, and it's the view of every provider I've ever known, is that people should be able to live in the environment that's closest to their own home as possible. If people can live at home, great. We want them to live at home. If they need a little less care and can work in an independent living facility or an assisted living facility, that's great too. Unfortunately, there are large numbers of older people that just need skilled nursing care. And so what a lot of the politicians don't understand, because they haven't been in the buildings enough, they don't understand the realities enough, is that the notion that there are a bunch of people that are living in nursing homes that can somehow be taken care of at home, it's just a myth. The average nursing home resident is around 85 years old. They have multiple activities of daily life that they cannot perform. It takes a couple of people to help them use the restroom. It takes a person to help feed them. They just have many more needs than I think that people visualize when they talk about this. So we love the idea of home care. We think it's great if they want to expand home care services. There'll be some people that will get those, but they won't be people that are currently in nursing homes. So if that is their plan, it's not a very good plan.
Only additional color I would offer is, as a provider in the rural space and as a provider that also has home care services, that segment is struggling for staffing almost as much as our skilled nursing providers. And so to think that we're going to be able to pivot and transition a bunch of resources, especially amongst the vast territories that we have here in the upper Midwest, I think there's a lot of things that we would need to work through to be able to get that, to make that all work.
Thanks, Nate. So a follow-up question from Alex Thorne with Skilled Nursing News. I was hoping to ask your thoughts on the Biden administration pointing at private equity and REITs as bad actors in the skilled space. Do you think this is fair? And are you concerned that it could steer investment away from the sector? Mark, would you like to take that one?
Yeah, I think a lot of the attacks on private equity are from people that just don't understand how financing of nursing homes works. And I don't mean to be critical of them, but the private equity market got very involved in skilled nursing in roughly the 2005 to 2015 timeframe. It didn't work out. And so the critics of those investments at that time are correct. Some of those investments that were made did not work out the way that you would have hoped for the residents, for the investors, or for anyone else. So those very large private equity firms, for the most part, exited the space. It's something like, although the data is not completely clear on this, only 5% of the buildings that are currently out there, the 15,000 buildings, are by private equity. So we're talking about 750 buildings. Any thought that you can dramatically change care in nursing homes by going after these 750 buildings is just, obviously not going to happen. The other thing I would point out is this, that over leverage in any sector, but particularly when you're trying to care for people, if you have too much debt, if your lease payments are too high, that's a bad thing. That can happen with private equity. It can happen with a REIT. It can happen with a bank. It can happen in a lot of different ways. What people really need to be looking at is leverage, super high lease payments. Those are the things that need to be addressed. The continued focus just on private equity. I'm not here to defend the private equity people, but it's looking in the wrong place for problems that do need to be solved.
Okay, we have a few more questions coming in. Next question we have from Steve Moran with Senior Living Foresight. Steve's question is, how much additional funding do you think it would take to attract enough people to work in nursing homes? Mark, you want to start with that?
Well, I'll be interested in Nate's thought on whether additional dollars can attract people or not. Our request for additional dollars is twofold. First, the need is twofold. First, we need to buy some more time for census to recover, because as Deb's data indicated, right now, a majority of buildings in the country are losing money. They're burning away the state and federal aid that's already been provided. And we need some additional funds to buy more time for that census recovery to occur. And then the second issue is on the workforce. There may be a dollar amount where we can increase the base wages enough that we can attract more people. And I would defer to Nate on what his thoughts are on that.
I would certainly agree with Mark. And I don't think there's any one of us that hasn't been out to a restaurant or, been to a ball game recently that hasn't seen those costs pass directly along to us as consumers to increase the wages of those employees at any venue. So for us to be competitive in our space, knowing that we do not have the direct ability to pass along those costs in most providers' cases, it just really creates an unsustainable situation. So, and I continually talk about it being a math problem. So we recognize that Medicaid rates, there's different shortfalls across the country, and yet, if we don't have the ability to continue to invest in our workforce, the best talent is going to go elsewhere. And so we absolutely need to continue to look at stable funding long term if we're going to compete with every other private industry out there.
Jesse Hillman with Modern Healthcare, Mark, wants to get a better understanding. What parts of President Biden's agenda do you think have to be done through Congress? I know we touched on minimum staffing already. Jesse also specifically asked about some of the transparency requirements.
Sure. So I think, the White House release itself acknowledges that the increase in civil monetary penalties, for example, would have to take place through Congress. An expansion of the number of buildings that are on the special focus list would have to be taken through Congress. The transparency stuff probably has to go through Congress. But having said all that, and Nate's on our board, so he can speak to this. We're interested in a lot of those things. We want transparency to occur. We want the buildings on the special focus list to get better. We want improvement, particularly of poor performing facilities. So we're not going to be out here fighting tooth and nail on these areas to where we actually think it could improve quality. What we will be fighting against are the provisions like the minimum staffing provision that just aren't possible to implement.
100% agree. We totally support transparency in a fair and equitable way, but the minimum staffing requirement would have devastating impact, especially on rural providers. For perspective, I often tee up that many of these locations, they only have a handful of nurses to begin with, and I would love to be able to hire and find more, but they're just not there and available. And so I think we got to be very careful and diligent in any type of approach there, especially one that's unfunded.
Great, thank you. I know we're running a little short on time on our end, so I'm going to go ahead and wrap up from there. Again, Mark, Deb, Nate, thank you so much for your time. To the reporters that joined today, thank you. We appreciate your time as well. Of course, if you have follow-up questions after today's call, you know how to reach the AHCA press office, and please feel free to do so. And with that, I think we'll wrap up. Thanks, and enjoy the rest of your day.